That there are 5 high-impact interventions that by implementing to scale will actually be able to achieve elimination of these epidemics.
With public health centered and evidence-based approaches, we are also helping countries to review, adapt, develop and implement effective.
Starts with Norway. Ronny from Kumar Net Drug Users in Norway. You have the floor, sir.
First of all, I want to say that I'm very proud of the Norwegian government, that they are pushing forward and speak about the needs and the value of harm reduction and human rights here in Vienna. And also the resolution on Hep C is a good example for that. Excuse my English, I'm not very good in English. Hepatitis C is a highly potent virus that needs to be addressed, and people, regardless genotype and liver stage damage, is entitled to get treatment. Hepatitis C is creating more sickness and health problems than both HIV and tuberculosis, so it's time to act strongly now. Luckily, more and more countries now have better access to medication. Those who made agreement with the pharma industry made it through ambitious plans and talked about elimination and a plan to treat all. And let's hope other countries will follow up and work towards that. National strategies are needed, and people who use drugs have to be involved and part of the strategy. I work in an drug user association, and the organization is run by people in OST. And we started engaging in hepatitis C for about 5 years ago. And at that time we had to educate ourselves. There was a lack of general information, basic knowledge of the virus, and few professionals were fighting for our rights to get treatment. Also, prevention was at a low level 5 years ago in Norway. There is still the need for better prevention tools like full user equipments. But the situation is getting better, and it's important to secure so we all have access to fully equipment. When we started 5 years ago, we made info materials, brochures available for our group, our members. We had several courses around the country where we invited people who use drugs to a meeting, and we told them about hepatitis C, what rights they had, and which kind of treatment that was coming soon to come. At that time, it was when we started working. Then it was a great need for awareness. You know, the professionals wasn't talking very much about hepatitis C, so a lot of things happened this 5-year period. And then we created a new website called hepc.no, where we have all the information people need to protect themselves and ways of treatment. And that was the time when the new DA medication was to be launched, so it was a critical time. Our latest project is our hepatitis bus, where it's a user-driven project. It's a caravan stacked with rapid test brochures. We also have a fibroscan machine available. We are traveling around all the country and visiting rehab centers, low threshold institution and places where people who use drugs stay. So it's quite an interesting project. So my mission today is to say to you that people who use drugs have to be involved in we are the key players if we are going to reach our goals of elimination by 2030. So we strongly would advise other countries to create contact with the drug using community and their organizations. You need us as a team player. And we hope this resolution will be appreciated and that countries that don't have access to medication will keep working towards to that. Thank you.
Thank you so much. Wangari Kimema is our next speaker. She will share some of their experiences.
Thank you very much, Ambassador. And apologies for the 5 minutes delay. I was in a field visit, let me begin by congratulating the Norwegian government for the resolution. And I also want to congratulate the communities back home because in India, unlike the erstwhile harm reduction program, here it was the PUD communities who made it possible for the government to kind of take it over less than a year back. It was 28th June last year, just soon after the World Drug Day, that this program was fully taken over by the government, and fully test and treat nationally is a possibility now. We still have some challenges in terms of the legal policy issues, but I think we are moving in the right direction. Early in the WHO presentation, we heard about the $35 costs for care and diagnostics. I just wanted to mention we are amongst the country moving in that direction, and again this has been possible because of a lot of mobilization by the community groups, very effective advocacy, and a lot of convincing with the government that happened. So the presentation I have, there are a lot of slides I'll quickly run through, but this I just wanted to mention that this is the presentation of the Government of India. I just happen to have the first slide. Rest it is of the Government of India, and they also extend support to this. I'll quickly run you through the structure of the India program. I won't focus on the data, a lot has been already talked. So I'll focus on the aims, objectives, the program management structure, linkages with existing program and new initiatives. We already know that 95% of the global hepatitis burden is ANC. It stands very true for India also. We also have, we don't have the absolute representative numbers when it comes to national program, but we have big enough number to act. We are also guided, like all of us here, by the WHO on this program, and if you see 90% of the modules, guidelines, they are similar in every country. So likewise in India also, WHO has helped us develop this, and the components of the program is in sync with the public health response. This is very important because in many countries the viral hepatitis program, especially the hepatitis C program, was graduating to the national HIV program for obvious reasons. It didn't happen in India that way. This program is completely under the Ministry of Health as an independent unit and is fully funded by the Government of India as a vertical program. It prioritizes evidence. It looks at prevention of virus transmission through immunization, blood safety, injection, safe water, and these are also reciprocal to the independent units within Government of India that is supporting this program. So there are 5 different departments that are linked. We also have the targets, and at this point there is a lot of lot of cynics feel that this may be unreal because we don't know the real numbers in India, and it could be far more than what we think. And sometimes one of the challenge I was saying in another forum this morning also, that no data seems like no problem or less problem. So in India this is a very important area. We need data, and in this particular area we are really lacking behind. So as I mentioned, the data is one of the issues. We already know that it's a big problem in India. I'll focus on Hep B and C more. So we already know that estimated 40 million people are living, and about 6 to 12 million people with chronic HCV infection. It's very important that when we're talking about HCV, especially, we are talking about PWIDs. And that is why a lot of emphasis in my next slides I'll talk about is about, in sync with the global campaign on finding the missing millions. So we don't actually know. So if you see, just 2 weeks back we launched our new drug use survey, and what we were pleasantly surprised with, the previous estimates for PWIDs in India was something close to 200,000, 177,000 to be specific. Now we are talking about, easily 10 times more than what it was. Methamphetamine users itself is about 1.2 million. So things are very dramatically different than what it seems when you look at it from the HIV program point of view. So we have the operational guidelines. We have identified the population groups, and not to mention that PWIDs are seen as amongst the most priority groups, because most of the infection, we know it more from the program data, from the interventions, we call them targeted interventions, but otherwise we don't have good data yet. Aim is to eliminate by 2030. I would like to focus on the problem areas. One of the problems, for example, is the law part. So what is happening in India back home is not so much about government putting the money and the tools and showing the willingness. It's more to do with the legal policy part, and one of them, it is to do with the disconnect between the provisions under the penal code and the drug acts or the HIV strategies that we have. So I think that makes it very difficult, because when you actually on ground, when you do the OST and the needle syringe program, there is still a disconnect in terms of people still get detained sometimes, and there is issues of access of services. Yes, so the talking of key objectives, as I mentioned, we already have the in the initial part of the program, the focus has largely been in terms of identifying where the communities are, looking at setting up the structure. So a lot of focus is around building capacities, building the human resource that needs to be made available, and also developing a structure, because this is a parallel structure from the national to the PHC level in districts. We need to do a lot of training and capacity building. Right. So since its inception in June last year, a lot of focus has been on awareness generation and BCC. If you look at the traditional harm reduction and HIV program, we are doing a lot of work around looking at co-infection and treatment literacy issues around that. We're also looking at provision of blood, safe blood and blood products, which is a grey area, looking at how transmissions happen in India. We're also looking at safe socio-cultural practices, because we have other issues around coax and other healthcare providers. So talking of diagnostics and treatment, the structure, I'll straight away come to the structure because it's 30 odd slides, I'm sorry. So we have a program management structure at the national level, which is basically the National Program Steering Committee, which informs the National Viral Hepatitis Management Program, and then there is a technical resource group which forms partners like WHO and other technical agencies, and that structure flows down to the public health center level. So this unit is what then informs the model diagnosis as well as the model treatment program. Just broadly speaking, you have the model treatment facility, you have a training structure which provides quality as well as training and capacity building for people, and then you have the treatment and diagnostic units. This is a PPP model. So you have the private sector helping with the test and treat program, and the government currently focusing a lot on the preventive and the awareness aspect. Right. I'll straight come to the financing part. As I mentioned, NHM is the National Health Mission in India. This is a very welcome step by the government because the entire program is supported by them. And then you have a state and center, federal and the provincial government partnership, so it's kind of coordinated very well. It looks like a very sustainable model, and what the government has done is They have prioritized the first 20 states out of the 31 odd we have in the country, and these 20 are the high prevalence one where they want to do a full saturation and then move into others. Some states like Punjab and Haryana have already gone ahead with their own programs, and they are taking the program forward. It's a completely coordinated program, so all different divisions, different arms of Government of India are involved. Most importantly, the National AIDS Program, which has already done a lot of ground mobilization and have the structures in place, they are involved. We have the tools available, and the same goes at the state level. Right. That's it. Thank you, ma'am.
Thank you very much. We mentioned at the beginning that we wanted to say just a few words about the resolutions that we're tabling. I'm not sure that we will have a lot of time to speak about it, but Anders Kjellvold, Senior Advisor from Norway, at least you can inform us on where we will meet next to discuss the resolution.
Yes, thank you. So the party can continue. We can move over to M5, where we will start the informal negotiations or discussions around this resolution in about 15 minutes. Just why do we do this from Norway? I think it's obvious after this session, but two things. We now know more about the severity of a situation and how much that severity is linked to drug use practices. So that's why it really belongs in CND. The second is, yes, good news. We don't that often have such good medical news. We can really make a difference. And we should start here in CND. So thank you.
Thank you, Anna, and thank you also to all our panelists. You were on time, and you kept the time that we had allotted. So thank you very much for your very interesting interventions. Thank you.